Hello everyone. The topic for discussion today is postnatal growth and development of craniofacial structures. The topic has been divided into three subtopics: postnatal growth of the cranial base, postnatal growth of maxilla, and postnatal growth of mandible. First, coming to postnatal growth of the cranial base. The postnatal growth of the cranial base takes place by three main mechanisms. First, cortical drift and remodeling. Second, elongation and synchondrosis. And third is sutural growth. First, coming to cortical drift and remodeling. This term remodeling is actually a combination of two phenomena, that is bone deposition and resorption. Bone deposition and resorption occur simultaneously, and this results in nothing but occurrence of bone remodeling. This bone remodeling results in changes in shape, form and position of a particular bone. Cranial base or the floor of the cranial base consists of a number of ridges and elevations. These ridges and elevations predominantly show bone deposition. Apart from this, floor of the cranial base also consists of a number of perforations. These perforations allow the nerves to pass through them and have its continuity with depth of the brain. Now, these foramina, which allows the nerves to pass through them and have its continuity with that of the brain, shows drifting by deposition of the bone. Hence, we can say that cranial base grows both by bone deposition or resorption, that is nothing but combined remodeling, and also cortical drift. The second most common mechanism by which there is development of the cranial base is elongation and synchondrosis. See, maximum bones in the cranial base, first they develop into cartilage. Cartilage then undergoes ossification and develops into bone. But some part of the cartilage still remains between two bony junctions. This part is nothing but called as synchondrosis, which nothing but acts as a growth site. Now, these synchondroses are present in the cranial base in the form of spheno-occipital synchondrosis, spheno-ethmoid synchondrosis, intersphenoid synchondrosis, and intra-occipital synchondrosis. We will know detail about each and every of these synchondroses. First, coming to spheno-occipital synchondrosis. This spheno-occipital synchondrosis is nothing but a cartilaginous junction between sphenoid bone and the occipital bone. The spheno-occipital synchondrosis is considered as the primary site of growth during the childhood, and it remains active till 12 to 14 years of age, and finally the growth ceases once the sphenoid bone and the occipital bone fuses with each other at an age of 20 years. The spheno-occipital synchondrosis shows a typical compression and pressure type of adaptation growth rather than tension adapted growth, which is usually seen in case of sutures. The typical structure of this spheno-occipital synchondrosis is two epiphyseal plates which are present back to back each other with a common zone of reserve cartilage in between them. And this spheno-occipital synchondrosis shows a growth in a typical upward direction. That means it carries the cranial floor in a forward direction. Next, coming to spheno-ethmoid synchondrosis. The spheno-ethmoid synchondrosis, as the name suggests, it is the cartilaginous junction between sphenoid bone and the ethmoid bone. This cartilage ossifies between 5 to 25 years of age group. Next, coming to intersphenoid synchondrosis. The intersphenoid synchondrosis is nothing but a cartilaginous junction between two different parts of a sphenoid bone. This synchondrosis or this cartilage usually ossifies at the time of birth itself. Last is intra-occipital synchondrosis. The intra-occipital synchondrosis ossifies between 3 to 5 years of age group. The third most common mechanism of the growth of the cranial base is by sutural growth. There are a number of sutures which are present in the cranial base. It can be sphenofrontal, frontotemporal, sphenoethmoid, frontoethmoid, and frontozygomatic. Each of these sutures is given a particular name based upon the two bones to which it connects. Like first, sphenofrontal, it connects sphenoid bone with that of the frontal bone. Next, frontotemporal, it connects frontal bone with that of the temporal bone. Here in the diagram you can even observe sphenoethmoid connects sphenoid bone with that of the ethmoid bone. Frontoethmoid and frontozygomatic connects frontal bone with ethmoid bone and frontal bone with zygomatic bone. Now, exactly what happens is during the course of its development or growth, as the size of the brain enlarges, it causes these sutures of the cranial base to open up. As the sutures open up, there is new bone deposition on either side of the sutures. This process continues till the desired or the required amount of size of the cranial base is achieved. Another most important thing I want to mention here is the cranial base actually by about at the time of birth is at nearly 45 to 55% of the adult size of the cranial base is achieved. And by about 4 to 5 years or maximum 7 years of age group, nearly 95% of the maximum growth of the cranial base takes place, and by maximum 10 to 12 years of age group, remaining 98% of the adult cranial base size is achieved. This was all about postnatal growth and development of the cranial base. Three main mechanisms should be remembered. Cranial base mostly grows by first cortical drift and remodeling, second elongation and synchondrosis, and third is growth at the sutures. Next is postnatal growth and development of the maxilla. Maxilla postnatally grows by three mechanisms. First, displacement, second, growth at the sutures, and the third is remodeling. We will know about all these three mechanisms in detail. First, coming to displacement. As the name suggests, displacement is nothing but simply moving or displacement of a bone from one point to another point. Now, this displacement of the maxilla takes place by two most common mechanisms. It can be either primary displacement or it can be secondary displacement. First, coming to what is primary displacement. Primary displacement is nothing but displacement of the maxilla because of the growth within the bone itself. Like the entire nasomaxillary complex consists of a number of bones. For example, if we take maxillary tuberosity is nothing but a part of the maxilla itself. So when bone deposition takes place here, it is nothing but a part of the maxilla itself. So when the bone deposition takes place at the maxillary tuberosity, it simply moves the maxilla in an anterior direction. This is nothing but called as primary displacement. Next, coming to what is secondary displacement. Secondary displacement is nothing but growth takes place in some other bone, and the forces are transmitted to the nasomaxillary complex, and the nasomaxillary complex gets moved in a downward and forward direction. If you see in the diagram, growth actually takes place at the cranial base. And since the nasomaxillary complex is attached to the cranial base by means of a number of sutures, as the growth of the cranial base takes place, these forces gets transmitted through these sutures, and this pushes the nasomaxillary complex in a downward and forward direction. So this is nothing but meant by displacement, which is primary displacement, secondary displacement. Next, coming to growth at sutures. Nasomaxillary complex consists of a number of sutures. It can be frontonasal suture, frontomaxillary suture, zygomaticomaxillary suture, zygomaticotemporal suture, and pterygopalatine suture. Now these sutures connects various bones of the nasomaxillary complex with each other. What exactly happens is, as the growth of the soft tissue takes place, this carries the nasomaxillary complex in a downward and forward direction. Because of this, the sutures gets opened up. As the sutures get opened up, there is deposition of a new bone on either side of the sutures to maintain the continuity. In this way, the size and the shape and the position of the nasomaxillary complex is altered or changed. Next comes surface remodeling. This surface remodeling, whenever it happens, it brings about three changes: increase in size, change in shape, and change in functional relationship. Now, as I've already mentioned, that remodeling is nothing but a combination of deposition and resorption, which occurs simultaneously and brings about the changes. Now, this remodeling changes occurs at various parts of the maxilla or the entire nasomaxillary region. First, coming to lateral surface of the orbit. The lateral surface of the orbit shows continuous resorption. Because of this resorption, the eyeball moves laterally. To compensate this, there is deposition on the medial aspect of the orbit. Next, coming to floor of the orbit. The floor of the orbit faces superiorly, anteriorly, and laterally, and hence deposition also takes place in the same manner. Next, coming to maxillary tuberosity. As I have already mentioned, that primary displacement. That is nothing but there is continuous deposition of the bone in the maxillary tuberosity. Because of this, the entire nasomaxillary complex of the maxilla moves in a forward direction. Next, coming to lateral wall of the nasal cavity. The lateral wall of the nasal cavity shows predominant resorption. This is to increase the size or the volume of the nasal capsule. Next, coming to floor of the nasal cavity. The floor of the nasal cavity also shows resorption, but to compensate this, there is deposition on the parietal aspect. Next, coming to zygomatic bone. The zygomatic bone shows deposition, and it moves continuously posteriorly by deposition on the posterior aspect and resorption on the anterior aspect. Also, the size of the face increases or widens by deposition on the lateral surface of the zygomatic bone. Next, coming to anterior nasal spine. Anterior nasal spine protuberance or anterior nasal spine is actually developed by more deposition of the bone in the anterior nasal spine. And to further accentuate its prominence, there is resorption just below the anterior nasal spine on the labial aspect of the alveolar bone. Next, coming to alveolus or the alveolar process. The growth or the development of the alveolar process actually occurs in response to the eruption of the teeth. As the teeth starts erupting, there is continuous deposition of the bone which takes place in the alveolar bone so that the width and the height of the alveolar process is maintained. So this was all about postnatal growth and development of the maxilla. If you remember that maxilla postnatally grows and develops by three main mechanisms. First is displacement, second is growth at sutures, and third is nothing but surface remodeling. The next topic is postnatal growth of the mandible. See, mandible is not a single bone. It is actually formed by a combination of multiple bones which unite together and result in the formation of one common bone which is nothing but called as mandible. So we will discuss in detail how postnatally each and every part of the mandible grows and develops. First coming to ramus of the mandible. The ramus of the mandible continuously grows in a posterior direction by deposition in the posterior aspect and resorption which occurs anteriorly. As resorption occurs anteriorly and deposition occurs posteriorly, ramus continuously grows in a posterior direction. This actually occurs so as to accommodate the increasing mass of the masticatory muscle and also to lengthen the mandibular body to accommodate the developing of the erupting teeth. Next coming to body of the mandible. As I have already said that as the ramus continuously progressively grows in a posterior direction, by deposition posterior and resorption anteriorly, the former ramen bone now becomes the body of the mandible, and like this it continues till the required amount of size is achieved. Next coming to angle of the mandible. On the lingual aspect of the angle of the mandible, resorption occurs in a posterior inferior direction and deposition occurs in anterior superior direction. Whereas this is on lingual aspect, whereas in case of buccal aspect, it's totally opposite to this. Next is lingual tuberosity. Lingual tuberosity is nothing but a direct equivalent to maxillary tuberosity. We can markedly see if we observe that lingual tuberosity shows a marked protuberance moving lingually towards the ramus. Now this protuberance or this prominence is accentuated by the more and more amount of bone deposition over the lingual tuberosity, and this prominence is furthermore accentuated by resorption which occurs just beneath it. This is nothing but called as lingual fossa. Next coming to alveolar process. As I've already mentioned in maxilla, that alveolar process growth depends upon the eruption of the teeth. As the teeth start erupting, more and more amount of bone is laid down so that the height as well as the width of the alveolar bone is maintained. Next is chin. Chin is actually one of the very most important characteristic of aesthetics. Chin is usually found in its well-developed form in the present man only. This chin is greatly influenced by various sexual and genetic factors and is more prominent in case of males when compared to that of females. The mental protuberance is actually its protuberance is furthermore accentuated by deposition on its surface and furthermore accentuated by resorption which occurs just above it, that is on the labial aspect of the alveolar process. So that because of this resorption, more prominence of the chin is made visible. Apart from this, the deepest point of the concavity, that means the resorption which is occurring just above the chin, is nothing but called as a point P. Next coming to condyle. The condyle actually is covered by a thin layer of cartilage, and this cartilage is actually believed and to have two main important functions. First, it itself acts as a shock absorber to resist abnormal forces acting on the temporomandibular joint, and second, it acts as a growth cartilage. There are two schools of thoughts for the growth of the condyle. The first school of thought says that the growth of the condyle actually occurs by directly deposition of the bone on the surface of the condyle. Now this is the condyle and this is the fossa. As direct deposition of the bone takes place on the surface of the condyle. Because of this, the condyle grows in upward direction and then it pushes itself in a downward and forward direction. This is first school of thought. The second school of thought says that this doesn't happen, but first the soft tissue grows. The soft tissue grows and takes the mandible in a downward and forward direction. The soft tissue first grows and takes the mandible downward and forward direction, and then to maintain this continuity with that of the cranial base, now the growth takes place at the surface of the condyle. Next coming to coronoid process. Coronoid process shows a typical growth in a V type of fashion. When the longitudinal section is observed from the lingual aspect, marked deposition of the bone can be seen on the medial aspects of the coronoid process. Apart from this, the same thing if it is observed from the occlusal aspect, this also suggests that the growth of the coronoid process takes place in a V type of pattern. Briefly, we can say that the coronoid process actually grows by having a typical propeller-like twist. This was all about postnatal growth and development of cranial base, postnatal growth and development of maxilla, and postnatal growth and development of the mandible. The development of dental arches and occlusion is being divided into following periods. It is pre-dental period, deciduous dentition period, mixed dentition period, and permanent dentition period. We'll be dealing in detail about each of these periods now. First, coming to pre-dental period. The pre-dental period begins from birth and continues till 6 months of age. The pre-dental period is actually characterized by the presence of gum pads. The gum pads are present in both maxilla as well in case of mandible. Gum pads are usually pink in color. They are firm and covered by means of a dense layer of fibrous periosteum. Upper and lower gum pads are usually almost similar to each other, but the upper gum pad is usually more wider when compared to the lower gum pad and is also more longer when compared to the lower gum pad. Upper and lower gum pads, when they come in contact, there exists a uniform overjet between upper and lower gum pads. And the upper and the lower gum pads usually comes in occlusion only at the posterior aspect, that is at the molar area, and anteriorly the gum pads remains open. This is nothing but called as infantile open bite. The gum pads are divided into two portions. It is labial or the buccal portion and the lingual portion. Both the portions are separated from each other by means of a groove that is nothing but called as a dental groove. Apart from this, each gum pad consists of nearly 10 segments, each segment corresponding to a specific deciduous tooth bud. These segments are separated from each other by means of grooves. These are nothing but called as transverse groove. This transverse groove between deciduous canine and deciduous molar is being given a specific name, which is called as lateral sulci. The lateral sulci of the mandibular arch is present more distal when compared to the maxillary lateral sulci, and these lateral sulci helps in determining the inter-arch relationship at a very early stage. The status of dentition during the predental period. Actually, when the child is born, the gum pads doesn't consist of any teeth. However, the width of the gum pads is very less, or it is very narrow so as to accommodate teeth. But as the teeth starts erupting during the first year of life, the size of the gum pad slowly starts increasing. Sometimes some children are born with teeth. Those teeth are nothing but called as natal teeth, and sometimes the teeth develops during first month of life. It is nothing but called as neonatal teeth. But these teeth usually have a very strong genetic predisposition. Next, coming to deciduous dentition period. After pre-dental period, next is deciduous dentition period. The deciduous dentition period runs from 6 months of age till 2.5 to 3.5 years of age. The deciduous dentition period is again characterized. First, the deciduous dentition period begins with the eruption of mandibular deciduous central incisor. As soon as the mandibular deciduous central incisor erupts, the deciduous dentition period begins. It is roughly at around 6 years. It is roughly around 6 months of age, and each and every deciduous tooth is being given specific time for its eruption. And the authors have even said that a mean average variation of nearly 2 to 3 months can be taken as normal from the actual age of eruption of a particular teeth. And the sequence of eruption of deciduous teeth is first mandibular deciduous central incisor erupts, then lateral incision, then first deciduous molar, then canine, and then second deciduous molar erupts. Now, the deciduous dentition period is also characterized by the presence of spaces. These spaces are actually considered as a positive sign in that it is present in deciduous dentition. Because if these spaces are present in the deciduous dentition, the permanent dentition will erupt or will come at a proper place. These spaces which are present in deciduous dentition are called as physiological spaces. Spacing invariably is also present distal to the mandibular canine and mesial to the maxillary canine. These spaces are called as primate spaces or simian spaces. Apart from this, another important feature of deciduous dentition period is terminal plane. What is this terminal plane? Terminal plane is nothing but mesio-distal relationship of upper and lower second deciduous molar. Now, if the distal surface of upper and lower second deciduous molar are in a straight line, as you can see in the first figure, it is called as flush terminal plane. Second is distal step, in which the distal surface of lower second deciduous molar is present more distal when compared to that of the upper. It is called as distal step. And the third figure indicates that the distal surface of second deciduous molar is more mesial when compared to the upper second deciduous molar. It is called as mesial step. Now, what are the various features of these terminal planes will be discussed in further slides. Next, coming to mixed dentition period. Mixed dentition period usually begins after the eruption of first permanent molar. Now, this usually occurs at an age of 6 years. The mixed dentition period can be divided again into 3 phases. It is first transitional period, inter-transitional period, and second transitional period. Coming to first transitional period. The first transitional period consists of two important phenomena. It is emergence of first permanent molars and exchange of incisors. Coming to first, emergence of first permanent molars. The emergence of first permanent molars actually occurs at an around of 6 years of age. And the emergence of first permanent molar depends to a great extent on the mesodistal relationship of upper and lower second deciduous molar. As I've already said that the relationship between the mesodistal relationship between upper and lower second deciduous molar is called as terminal plane. If the distal surface of upper and lower second deciduous molar are in a straight relationship, it is called as flush terminal plane. Whenever in the deciduous dentition this figure indicates that flush terminal plane exists, the permanent molars will also erupt in end-on relationship only. Now for this permanent molar to move from end-on relationship into class 1 relationship, the lower molar has to be moved mesially forwards. Now this movement takes place by two phenomena. It can occur either by early shift or it can occur either by late shift. The term early shift is actually given because this phenomena takes place during the early stages of the mixed dentition. The term late shift is given because this phenomena occurs during the later periods of the deciduous dentition. What exactly is the meaning of early shift? Now, as the permanent molar erupts into the oral cavity, it creates certain forces. These forces are itself sufficient to push the lower mandibular first molar anteriorly forwardly. As it is pushed or moved forwardly, it automatically achieves angles class 1 molar relation. Now next, what is late shift? In late shift, these are the children in whom physiological spaces might be absent. Under such situations, after the exfoliation of second deciduous molar, now the first permanent molar erupts into the oral cavity and utilizes the primate spaces and achieves class 1 molar relationship. Next, coming to what is distal step terminal plane. In case of distal step terminal plane, as I've already mentioned that the distal surface of lower second deciduous molar is more distal when compared to that of the upper. Under such circumstances, the permanent molars will also erupt in the same relationship. This will result in occurrence of a correct class 1 relationship. Next coming to, this results in development of mostly class 2 molar relationship. Next coming to mesial step terminal plane. In case of mesial step terminal plane, the distal surface of lower deciduous second molar is more mesial when compared to that of the upper second deciduous molar. Now the permanent teeth usually develops in angles class 1 molar relation only. But this occurs if the growth doesn't continue. After the eruption of the teeth into class 1 relationship, if still further growth continues, then from class 1 relationship, this will develop into class 3 molar relationship. Here in the first diagram, we can see how the distal step is there. And in the second, you can see how the mesial step terminal plane is there. The second most important phenomena which takes place during the mixed dentition period is exchange of incisors. Exchange of incisors is nothing but exchange of deciduous incisors with that of the permanent incisors. It is quite well known that deciduous incisor mesodistal diameter is a bit less when compared to that of the permanent incisors mesodistal diameter. Now this difference is nothing but called as incisor liability. The incisor liability is about 7 mm in the maxilla and is about 5 mm in that of the mandible. Now, since the mesodistal dimension of the deciduous tooth is less when compared to the mesodistal dimension of the permanent teeth, when the permanent teeth have to come into the oral cavity, it usually lacks space. So this lack of space is usually overcome by three mechanisms. It is first utilization of the interdental spaces which is seen in the primary dentition. As I've already mentioned that primary dentition is characterized with the presence of interdental spaces or physiological spaces. At this stage, those physiological spaces are utilized for the permanent teeth to come in proper alignment. Second, it is increase in intercanine width. During the exchange of deciduous teeth with that of the permanent teeth, automatically there is increase in the intercanine width. This increase in intercanine width also helps in proper eruption and alignment of the permanent teeth. The last is change in incisor inclination. As we observe that the deciduous teeth are mostly erupt in an upright position, but the permanent teeth mostly erupt in a more inclined position. So when they erupt in a more proclinal or inclined position, it automatically results in increase in the arch length or arch width. The third is intertransitional period. In this intertransitional period, there are sets of deciduous teeth and the permanent teeth which are present in the oral cavity. That means between permanent incisors and permanent molar, deciduous canines and deciduous molars are present. This stage is characterized wherein there is no changes occur. It is stable. This stage is actually a stable stage. Next, coming to second transitional period. The second transitional period is the period which is characterized by exchange of deciduous molars and canines with permanent premolars and permanent canines. Now, here also the mesodistal width of deciduous canines and deciduous molars is comparatively more when compared to permanent premolars and permanent canines. So there is surplus of space which is present. This surplus of space is nothing but called as leeway space of Nance. The leeway space of Nance is more in the mandible when compared to maxilla. It is about 3.4 mm in the mandible and is about 1.8 mm in the maxilla. Now, this leeway space of Nance, as I've already said previously, that this leeway space of Nance is actually utilized, since it is present more in the mandible, it is utilized by the mesial movement of the molar to achieve class 1 molar relationship. Next is very important feature of this stage is the ugly duckling stage. Ugly duckling stage is nothing but a stage which is nothing but also considered as self-correcting malocclusion. This usually runs from about 8 to 9 or roughly 10 years of age. What exactly happens, you can observe in the diagram that as the permanent canine starts erupting into the oral cavity, it creates a mesial force on the roots of the lateral incisors. Now, as there is mesial force on the roots of the lateral incisors, they starts getting divergent in a distal direction. As they get diverge distally, the roots of the lateral incisor also exerts force on the roots of the central incisors. Hence, centrals and the laterals shows a distal divergence. Because of this, there is opening up of a midline spacing and midline diastema appears. Since the parents are more concerned about this stage, as a child starts looking a bit ugly, the name of the stage is given as ugly duckling stage. But this is a self-correcting malocclusion. As the canine starts erupting, the forces starts getting transferred from root area now towards the crown area. And in the third diagram, we can see once the canine totally comes into the oral cavity, the forces gets transmitted from root, and now it gets transmitted towards the crown area, and slowly all the teeth comes at the correct position, and the midline diastema closes. Next, coming to the permanent dentition period. It must be remembered that the development of the permanent tooth buds actually occurs after the birth, except for the first permanent molar, whose development usually begins before birth itself. And the mandibular first molar is the first tooth to erupt into the oral cavity. And the sequence of the eruption in the mandibular arch is first permanent molar, then central incisor, then lateral incisor, then canine, then first premolar, then second premolar, and then second molar. Or it can be first permanent molar, then central, then lateral, then it can be first premolar, then canine, then second premolar, and then second molar. In case of maxillary arch, one of the most common sequences, first permanent molar, then central, then lateral, then first premolar, canine, second premolar, and second molar. Or it can be first permanent molar, then central incisor, then lateral incisor, then canine, then first premolar, second premolar, and then second molar. So this was all about development of dental arches and occlusion. Thank you.